Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Alice Gallo de Moraes.
Hi, everyone, and welcome to the Chest Journal podcast. I am Alice Gallo, an intensivist at Mayo Clinic in Rochester, Minnesota, and I am delighted to talk with Dr. Cheng Wei and Dr. Po-Cheng Shih about their article on this month's Chest Journal. Comparative effectiveness of Tocilizumab versus Rituximab in Rheumatoid Arthritis-Associated interstitial lung disease. Welcome, Dr. Wei, and welcome, Dr. Shih, to the podcast.
Hi, everyone. I'm James Wei from Taiwan, Taichung Zhongzhen Medical University.
Yeah, thank you for having me today. My name is Po-Cheng Shih. I'm a rheumatologist working in Cheng Wei Christian Hospital in Taiwan, and now study in Zhongzhen Medical University under my mentor, Dr. Cheng Chung Wei. Yeah.
Amazing. Thank you so much for joining me. And I was hoping to start with both of you telling me a little bit about your clinical day-to-day work and what inspired you to look into the effectiveness of Tocilizumab versus Rituximab in RA-related ILD. So Dr. Wei, let's start with you.
RA, rheumatoid arthritis, is a difficult disease, which is autoimmune and sometimes very severe, especially for RA with ILD. So we have been studying RA-ILD using the big data for a while. Actually, this is only one of our 5 papers in the past 1 year. So I think, Po-Cheng, maybe you can mention about the detail of your background about this study.
Yes, thanks for the Professor Wei. I think in ILD, especially in the treatment of the ILD, there is limited of the high-level evidence currently. We could see in HRTS guideline and the ERS and URA guidelines, they all mention there is maybe the conditional recommendation or low-level evidence for us to choose the therapy for the ILD. And we know in recently, Rituximab probably has the most real-world experience in ILD. But we know it is not the only reasonable choice, either for RA or for ILD. But the current guideline and the current evidence suggest maybe for the individualized approach, but without solid evidence for us to choose the appropriate biologics. And we know in previous studies for these biologics, almost small and retrospective cohort study, that ablacept Tocilizumab or the Rituximab might help stabilizing the progression of the ILD, either in HRCT pattern or extend or in the FVC pulmonary function. But this limitation is rather high level or the large enough head-to-head evidence still limited. So that's why we want to do this study to get more evidence, maybe to lead the clinical practice, because we always face many RA patients every day, and the ILD is not a very rare complication or a very rare organ involvement in RA. I think it is usually emerge in our OPD. Yeah.
Thank you so much. I love that. So making sure that we are making sure that we know that there are many options, but are comparing medications that could potentially work that have not been compared head to head. I love it. So tell me a little bit more about the study design, and I was hoping you could tell us more about what does target trial emulation mean here.
Okay, let me start it. Okay, so if you want to answer drug-drug comparison, traditionally will be a clinical trial by head-to-head trial, but this is very time and also money wasting, right? So generally, it's very difficult to do a head-to-head clinical trial, but we still need that data in our real world to treat our patient. So my group, we are using a real world data, but it's a big data, a very big sample size, so that you can retrieve data from the different kind of drug user. And then after a very well study design, you can compare the effectiveness between those two drugs. So we call this is a target trial emulation. What is target trial? You just like to emulate a clinical trial. So that is a target. But this is not a real clinical trial. So we call it target trial emulation. So in one sentence, we are using a real world big data to emulate a clinical trial to show a closer evidence to a randomized clinical trial.
Yeah, let me for something. The key practical point in the target trial emulation is we have a framework for this emulation. We say the time zero at the treatment initiation, so we avoid the immortal time bias. And after that, using the well matching, and we use the propensity score matching method to balance the baseline. To help reduce confounding by indications, which this bias is usually occur in the observational design before, but it always the emulation, but it saves money and maybe let us to find a probable answer fast. Yeah, I think.
I love that. So using big data to emulate a clinical trial that will be very time consuming and resource consuming, and getting good results to help our patients. I absolutely love that. Anything else you would like to share with our listeners about your methods that are unique and you would like to highlight?
Yeah, I think the bottom line of a successful TTE design will be number one, you need a very big and good data set. Usually we need a very large sample size, more than millions or even more. So right now we are using a global EHR data set we call Trinitex, which is a US company based in Boston. They just use a technique to link the EHR for different kind of hospital. So they generate more than 2 million, or I would say more than 200 million population in that data set. So with that good and big data set, then you can make the TTE design possible. So this is good. The number one will be a data set. And number two is the study design. Just as Po-Cheng just said, you need a very vigorous study design to matching two groups, to matching their baseline severity to avoid any possible biases. So you need more different kind of subgroup analysis, different kind of matching, and many different kind of sensitivity tests to show the robustness of the result. I think those two elements is a successful key for TTE papers.
I love that. Thank you so much for highlighting that, Dr. Wei. So let's move to your key results. So share with our listeners, what were the things you found?
Yes, due to this, the database is very large, so we have included 1,194 initiated in each cohort, Tocilizumab and Rituximab, and then we match them on a broad set of the baseline characteristics. After the match analysis, Tocilizumab and Rituximab show comparable long-term outcomes on the primary and secondary endpoint, which include all-cause mortality and hospitalization, and the need for mechanical ventilations. So this is our key results. And in our abstract, we have highlight results from the sensitivity analysis. We have found if the patient with the baseline higher inflammation burdens, such as ESR higher than 30 or CRP higher than 20, within the prior 6 months before the Intersti, that Tocilizumab show a higher risk of the all-cause mortality and need for mechanical ventilations. So it is a clinical important signal, and maybe that warrants confirmation and may suggest we should be more cautious when the baseline information is very high and the respiratory risk is substantial.
Dr. Wen, anything else to add?
Yeah, I think the conclusion is that generally two drugs are comparable, okay, generally, but in some subset of higher inflammatory subpopulation, Rituximab will be better than Tocilizumab.
That's awesome. And how about what should we be telling our colleagues who are in clinic, like talking to their patients about starting these medications? So like what would be some pieces of advice that you would have for them in terms of like bedside ILD management?
Yeah, I think in current evidence, more and more evidence saying that the patient with ILD, maybe we may use a non-tumor necrosis factor inhibitor biologics for these patients. The overall results in recent decades show that. And inside for this group, we have the abatacept and Tocilizumab and Rituximab. And in our analysis, Tocilizumab show and Rituximab show the comparable results. So Tocilizumab could be considered a reasonable alternative to Rituximab if the patient have maybe some infusion reaction or other adverse events after use the Rituximab, or may have some infection concern. Yeah. So if Rituximab is available, Tocilizumab is a reasonable alternative. And second, the patient selection matters. If a patient has a very high inflammatory activity in baseline, you should, and I will discuss with the patient, we should be more cautious with Tocilizumab used. Like just our sensitivity analysis show these signals. So we should have the patient selection. Yeah. And the third, we need to clarify the study is not a one drug fits all. So in ILD, we still need shared decision making, and we need to discuss with the pulmonologist and maybe the other radiologist for all the picture of this patient to have a baseline risk identification, and we need to more close follow up. So our study, I think our study and our evidence helps to inform one specific decision point in routine clinical practice that Tocilizumab has limited evidence before. So our study help these points. Yeah.
Thank you so much. I love that. Dr. Wen, anything else to add?
Yeah, actually, we have many immune target therapy right now.
Yeah.
In this study, we only discussed about Rituximab and Tocilizumab. So don't forget, we still have abatacept and also JAK inhibitor and also TNF inhibitor. Yes, both useful in RA, but in RA-ILD, I think some of them maybe have some different. So generally, we don't like TNF inhibitor in RA-ILD because of some small studies showing that actually they are harmful for RA-ILD. So currently, in clinical practice, many clinicians will choose Rituximab first. But again, in some different stage, different phenotype, sometimes you can consider abatacept. And also sometimes you can consider Tocilizumab or JAK inhibitor. So I think we can do more comparison in the future studies.
But would it be fair to say that this is one step in the right direction of making connective tissue disease related ILD being very personalized, receiving personalized treatment?
Yeah, you can say that, or depend on different stage. You have inflammation stage, you have fibrosis stage. That could be different on the drug selection.
I love that. Thank you so much for making sure that we talk about this nuance. So tell me, let's start with Dr. Shih. Tell me, give me 2 or 3 clinical pearls that you would love our listeners to take home from your paper.
Oh, yeah. First, from the guideline to our analysis, in ILD, we always to weigh the biologic choice through both joint control and lung risk, pulmonary risks, and our heart outcomes matters. So, and the second, our real-world comparative evidence suggests Tocilizumab may be a reasonable alternative to Rituximab in many patients, but selection is the key. Remember the baseline information you should check. And the last, we always mention if the patient with a different situation, the therapy should be personalized or we say individualized to have many discussion, I think.
Thank you so much. How about you, Dr. Wei? 2 or 3 clinical pearls for our listeners.
Yeah, maybe I can add one more thing about safety. Don't forget safety first before effectiveness, okay? So different drugs have different kind of safety signal. For Rituximab, yeah, you really need to care about some chronic hepatitis patient or some other infection risk, which is higher than other drugs. So when we comparing the effectiveness or efficacy, but you still need to select the risk. It depends on different kind of drugs. So we do a baseline check for the risk of cancer or risk of infection first. You need to know the hepatitis B, hepatitis C, or even tuberculosis before you choosing the drugs. Then you compare the effectiveness. So that's our thinking process.
I love that. Anything else? Anything else you would like to tell our listeners about your paper?
Po-Cheng, you first.
I think from the guideline and from more and more evidence emerging in ILD, we may change our clinical practice maybe day by day. So we need to update and we need to take care of every patient with the personalized approach. And just like Dr. Wei says, the safety and the effectiveness and all the domain of the RA, we always should take in our heart, I think. And we need to close monitor the every aspect perspective in the patients. So now we know the non-TNF inhibitors is maybe the primary choice for the ILD, but maybe in the near future, the Janus kinase inhibitor, maybe they have their role in the patient with the ILD. So back to our paper. I think in current evidence, all the non-TNF inhibitors are alternatives or are reasonable choice for the ILD, but you should take care of all the perspectives in of the patients. So we are not just focused on ILD. We are focused on this patient, I think. Yeah.
Love it. Dr. Wei, anything else?
Yes, I need to address one thing more.
Yeah.
That this is a TTE, a target trial emulation, is one kind of real-world study. And the real-world study is only show the association of the exposure and the outcome. We are not talking about the causation or the real evidence. So you still need to do randomized control trial if possible. So, but in current, our approach is that if you show signals in TTE, then you can use that to design your RCT. So to make your RCT more chance to be successful, we even can calculate the sample size you need or the duration you need to show the difference. So for methodology, I think this is a big breakthrough that using big data first to show the signal of association. Then you go back to RCT to show the evidence of causation.
I love that. That's amazing. That's a great parting gift for our listeners. I absolutely love it. Thank you so much for joining me this morning here where I am and this evening where you are. So I really appreciate you joining me today. And I hope you enjoyed listening to Dr. Wei and Dr. Shih on their comparative effectiveness of Tocilizumab versus Rituximab in Rheumatoid Arthritis-Associated interstitial lung disease for this Chest Journal podcast. Again, I'm Alice Gallo, an intensivist in Rochester, Minnesota, and I appreciate you all listening to us.